It's a bird.
It's a plane.
It's the Glute guys.
Howdy, everybody. Welcome to the Glute Guys Network. Today we have another special guest, Dr. Holli Hornlien, PT, DPT, OCS, a pelvic floor therapist. Holli, welcome to the show.
Hi, thank you for having me tonight.
Hey, hon.
Hi.
I'm from the office. That's my fiance, everybody.
That's right. Excited to be here.
Also known as the most beautiful girl in the world, and I'm not biased.
That's my wife.
We paid him to say that.
Well, we obviously have to start off with a toughie. So the question is...
The hardest question.
How did your fitness journey start? And how has it impacted your career and personal life?
How did it start? I want to say in high school, I ran long distance track and then fell in love with it. Did a lot of running, trained for my first half marathon then. I did one in college. I didn't do any sports in college. I kind of just kept up with the running. And then at some point, I transitioned into weightlifting. I can't remember when. It might have been in PT school when I realized, wow, I have no muscle and we're responsible sometimes for like transferring and carrying patients. So I was like, I think I need to start working on that. Probably fast forward maybe 5 years, still a mix. I got very, very, very into weightlifting. I liked the feeling of lifting weights once I got into a routine. At first I was miserable because I liked the running. And then I started to see some really good positive changes, like body comp changes, more muscle mass put on. So that was like motivating and fun. And then you realize how strong you are. You can lift up heavier things than you thought. So, you know, from then to now, I do a mix of both. I still love to run. There's something about it that like brings me back to those days. But mostly I'm into weightlifting now. I think too, like throughout that, you asked like how it shapes my career in a way. One, it's so interesting to see how the body changes, how much control we do have over manipulating it. It takes time and effort, but it's very interesting to see what happens. And then obviously it's healthy to exercise, especially weight training. Oh yeah, duh. I remembered strength training. You know, they say, what is it? At 30 years old, you start to lose muscle mass if you don't work to maintain it, right? Very slow over time, but as we age in general. So that was a big factor. And I was like, oh my God, I'm like 21 and I have no muscle. Like what's going to happen to me? So that was another factor in weight training and shape my career. Yeah. I mean, it just gets me excited. I always say if you move well, you feel well and you live well. So weight training, being strong, moving well, all good things to help you experience your life better and more efficiently as a whole.
And Holli, you obviously forgot a huge part of your fitness journey, which was when you did flag football in college.
I was nervous that was going to come up. Oh yeah, so there was no muscle. Yeah, flag football. You giggled like this every single day that I told you I had practice, number one.
Somewhere I have a video of your flag football team.
Of my interception.
Yep.
What's really okay, so that I was gonna get into that because when we first started dating, Aaron numerous times told me that over and over and over again to ask you about flag football and the interception.
And did you? I don't think that you did.
No, we talked about it. I was just saying, I remember the interception. Yeah,
I think you were very proud of organically.
I think so, but he would always bring it up.
Yeah, I'm sure. He laughed at me every time, and I was like, "What? I'm intimidating." Absolutely not.
It was one of the
then.
It was one of the most athletic performances I've ever seen.
Yeah.
CB1. I wasn't there to see it, but I believe it was CB1.
Yeah, not super athletic, like coordinated ever, really. I did a presentation once on running, and I was like, oh, a pro is the fact that we all innately know how to run. It really, you know, right? We all know how to run. It's like,
you can't argue with that.
Nope.
That is true.
It's like pro.
Turn on the fight or flight response and we'll start all sprinting. So
yeah. Mm-hmm. No contact.
No, but you mentioned a lot of good things, like the health benefits that we have with weightlifting. A lot of people think it's just Just if you want the muscle. But like you just said, after 30, you start to see what Aaron and I talked a while ago about. Actually, Aaron, I forgot that you're above me now, I think. You changed the format. Okay, so I'll look like this when I want to talk about you. That sarcopenia, it starts to kick in. We start to lose muscle over time. So it's a good way to reverse it is by just weight training and staying healthy with cardiovascular activities.
And Holly, I think you started to go into it a little bit, but how did all that stuff impact like becoming a physical therapist and I guess your career now?
How did it all impact my career? I think it helped me realize that you can push people a little bit more than I used to, think like you're stronger than we realize. I've always had an interest. It actually pushed me into physical therapy. A lot of people say that from the get-go. When I got injured, I had an Achilles strain and couldn't run, and it took like a while to rehab. And I thought it was so cool that the trainer at the time and PT at the time were able to figure it out. It was like a big puzzle piece, and they knew what to do and piece all the layers back together. And I thought, man, this is really cool. Before that, I was gonna be an interior designer and own my own business, and then that happened. So that shaped the start of my career. And then, kind of both unfolded together and transitioned together. I always loved what we were learning in school. It was one of those things like, school's hard, but you're learning these things in bio, anatomy, and I loved it. I loved every second of it. So I guess, that learning a lot of what we learned in school, starting my career, also helped motivate me to go to the gym, stay active, stay healthy, and they kind of led into each other, I guess vice versa. So yeah.
Yeah, you can tell how passionate you are by how much you just enjoy classes. I think I was the same way. The stuff that had to do with what we were supposed to be doing, I always liked. And then the other stuff, like contemporary moral issues, I was like, oh, this is terrible. I could barely sit through this class.
Yeah.
All the extra little add-ons that they made us take just to meet the credit requirements. I always hated those ones.
Yeah.
Never fun ones.
You want to take a little nap through those.
Oh, except for our history professor, Aaron.
Yeah, I guess we shouldn't shout out any names.
He would scream at you if you kind of even doze off. He would slam on the desk and scream at you in front of the class. And then Aaron did fall asleep one time, and he didn't say anything, and I couldn't believe it. He liked you, I guess. I don't know.
I got away with it for some reason. I don't
probably
know
Aaron, because you're 6'3" and you're probably bigger than him. He's probably afraid you were gonna just beat him up in class.
I mean, it's possible. I was always very nice to that guy. I did pretty well in that class too.
Aaron, even though you were nice when I was playing rugby with you, if I ever got paired up to do drills and stuff with you, I didn't want to practice anymore.
Well, that's a different story. When I play sports, I'm a completely different person.
Yeah, you were. Yeah, I didn't want to practice tackling with you. But anywho, somewhere along your physical therapy career, we found and discovered pelvic floor therapy.
Yeah,
which is it's something very specific and it's very very niche. Not everybody treats pelvic floor, and I think it'd be more fun to spin the first question around on me and Aaron as we try to say what is pelvic floor therapy. So, Aaron, do you want to start with that one? What do you think?
I think Aaron has to start.
Yeah, because Tommy,
I might have been educated a little bit.
Tommy has a little help having a fiance that is in pelvic floor therapy. I feel like everything is always hard to say in a short description, but if I had to describe pelvic floor therapy, I guess it's trying to work with people to activate maybe pelvic floor musculature in order to help with certain things that affect the pelvic floor musculature. So, for example, maybe getting a C-section, so that goes through all those abdominal muscles and retraining how to use all those different things. Or something like maybe like a hernia of some sort where you have to have surgery and repair something like that. Or maybe not along the muscular part of it, but maybe more neuro if you have some type of incontinence, working on improving the control of those type of things. So coordination and muscle activation, things like that. That's all I got.
Pretty good. That's really good.
Yeah.
I'm proud of him.
I'll be fair and say what I first thought pelvic floor therapy was before I got educated, because I think that's the only fair response. I now know much more about it because of my fiance. But before, I just thought it was the treatment for like incontinence and bowel and bladder related issues, as well as like postpartum related issues. And then I had a whole door open up and shown that it's a lot more than just that. And I always understood, the pelvic floor has a lot to do with like core stability and everything too, but there's a lot more that goes into it. So Holly, let's educate us and teach us, one, how did you get into pelvic floor therapy? And
Right.
two, what is it in a nutshell?
Sure. So I got into pelvic floor therapy. I think it was introduced to us in school. We had like a 2-hour lecture, a little bit, very little on the anatomy. She spoke more about her experience as a PT, a pelvic floor PT. And then I remember learning more about learning when should you refer out to pelvic floor. We didn't learn so much about what that day-to-day would be like as a pelvic floor therapist. Were like red flag kind of screenings. But I thought it was interesting. I thought, oh, okay, she's running her own program here at the hospital that she worked at. I was like, oh, maybe, who knows? And then I kind of graduated, got into like outpatient ortho, like high volume, fast. And then I started thinking to myself, well, thinking back to that pelvic floor thing. And then I switched jobs, and then at the clinic I work at now, they had a few pelvic floor specialists already there. So I was like, I just reached out to them. My manager was very, very great about us shadowing, so like taking clinic time to go learn more. They were very good about that. So, asked her a few questions, told her I was interested. And she basically let me come and shadow some of her sessions, and she was 100% pelvic floor. At this time, we don't even have that now. A lot of us have a mix, but really, really good. Just observation, hands-on. Asked her a lot of questions. I had a lot of guidance from other therapists, I'll say, because there was many of them who I got to talk to, and they really gave me the sense of like, okay, what are you treating? How are you helping people? And, and then you talk to the patients and you see their relationship as you're shadowing, and you're like, wow. The biggest thing that drew me to it was the change in people's lives over things that no one wants to talk about, but so many people are dealing with. That was what really like drew me into it. And I was like, wow, like I feel like I could talk to like a brick wall. And I feel like being the advocate for people in these experiences, is very, very impactful. So I thought I could really make a difference in someone's life in that regard. So to put it in a nutshell, then I took my first course, and then that was back in, I want to say 2021. It's maybe 2020 now, so 4 or 5 years. And ever since then, I've had that caseload. So right now, well, what is pelvic floor therapy? We'll go there. It's a wide range of like diagnoses, if you will, but I would take what both of you said and kind of combine it, right? It could be anything from pelvic pain, prolapse, incontinence, urinary or fecal incontinence, anything going on, postpartum, even peripartum, pregnancy related, back pain, sciatica, those kinds of things. So diastasis too, separation of the abdominal wall, post C-section. Hopefully I'm not forgetting anything, but to try to keep it broad and big, that's what we'll treat. And so what is it? Again, Aaron, I think you talked about too, like talking about retraining the muscles, working on that coordination, educating the patients on what is even happening in their body. What does that part of their body even look like is a big factor too. Making people feel comfortable with what they're coming in for is also another factor. I think too, like these are things that, sitting next to a friend or something, you don't really talk about, like that having fecal or urinary incontinence, like, hey, I wet myself, 3 times a day, I can't hold back the urine. No one really wants to bring that up. Commonly too, you see a lot of mothers who will, I guess, joke about the fact that when they cough or sneeze, they have to like squeeze their knees together, or they just kind of chalk it up to like, oh yeah, that happens to everybody. And just because it's common doesn't mean it's like expected or something's within normal ranges or means, right? So, and then I kind of feel like, well, why not try to do something about it? Like, you don't always have to live that way. And it's very, very inconvenient for people. I'm going on a tangent now, but who want to keep everything dry, or like they'll say clean down there. And then, the lifestyle is also impacted. So, you're going to work and you're bringing extra liners with you, you're existing in an office outside of your house. You're bringing backup underwear, backup pants sometimes, just in case, So it's not just some discomfort. There's a whole lifestyle adjustment that goes with that too. And if you can give that back to someone, I think that's like a really special place to be.
Yeah, I could actually.
Definitely. I'm
sorry. I can definitely actually relate that to working with geriatrics. Sort of similar, but sort of very different at the same time. But like just getting people like back to like the little things that a lot of people take for granted. Like incontinence is something that a lot of people don't think about, and when you're dealing with it, that's a pretty big thing to think about. And it's like, for me, it's patients just like walking to the fridge or walking around their house, getting to the car, little things like that most people don't take for granted. And when you start seeing people doing that again, it's pretty rewarding. It's pretty nice to see.
Yeah, I think that it's amazing that you're able to work with these patients and give them that piece of their life back, because it happens. I mean, like you said, it happens with women postpartum. It can happen with men too, and it can happen at any age. Like we might have friends walking around who have issues that, like you said, they don't want to talk about it because it's sensitive and embarrassing at times for sure. And you give them that piece back and give them their life back where they don't have to worry about that anymore. So it's really amazing. And I feel like personally, before like you taught me a lot about it, there's not a lot of people out there who know that there's something like this that they can do. So it's amazing that it's spreading and growing more and more, and that more people are seeking help. And I just think it's amazing that you can give them that piece of their life back.
Yeah, I forget the actual number and statistic, but so there is, before we go into that, male and female pelvic floor. I tend to focus more on female because that's where my little niche is right now. But yes, male pelvic floor as well. Similar things, but a lot of, what was the statistic? I can't remember the exact number, but multiple doctors, people have these diagnoses, these impairments, if you will, and they go see multiple doctors before they get to the point of reaching a pelvic floor therapist. It might have changed because, like you said, the awareness is a lot better now, even though I feel like for men, it's still not where it needs to be. But they see multiple doctors before they get to the place of, okay, working on something that teaches them that coordination, or, we look at other things other than just what's going on maybe on an organ physiology level, right? And how can we piece that back together for a person to help with function? So it's pretty crazy sometimes, and they finally get to us and we're like, yes, but we wish it was sooner. So still, even though it's well known, it's super important.
It's definitely something that, like, in my population could be used a lot more, honestly. Like, that I don't think that most people even think about, like, pelvic floor type of stuff. And it's tough, too, because it's tough to refer someone just for pelvic floor, I think, because, like, we have all this other stuff to work on as well. Not saying that it's not important either. It's just, like, it's hard to, I guess, sort out when to refer or not when a person's like having trouble, like I said before, like getting around their room, doing the little things that they're having trouble doing too.
Yeah, it definitely can be. Or if that's maybe not the primary reason they're coming to you, you're saying like, well, how do I bring that up? Like, they'll say something to you and then, you've had this conversation, you might think in the back of your head, oh, that kind of sounds like they might need it. I mean, even before I was a pelvic floor therapist, I would kind of just bring it up to them and say, hey, if you're interested, there's this kind of PT out there. They, will treat X, Y, and Z. I always tell people, like, it doesn't hurt to get an evaluation. Maybe they go back, talk to the doctor, or to get the script or whatever it is, how it works for them and their insurance. But, education is on your side. And it never hurts to just explain what's out there for people. And then if they want to pursue that further, they can, and an eval, I say that never hurts to go get it looked at, talk to someone what's going on, and then go from there.
I say that a lot.
Definitely. I think.
Yeah, it never hurts.
Oh, yeah.
Better to try it, and then hopefully it works. If it doesn't, who cares?
Listen, when it comes down to it, it's better than trying like 50 million different types of medications because I mean, not that medication's bad, but it's like we don't want to take pills for everything when we have different fixes that we can go and try to, and it's helping now that I feel like more and more doctors are starting to become aware of it too. So they're willing to try a less invasive style of treatment before jumping to a medication, or tailoring the two of them together to see if you can kind of give the best of both worlds, patient dependent, of course, too.
Yeah. Oh yeah.
Holli, I don't know if you know the answer to this, but are there like any studies or anything comparing medication to pelvic floor physical therapy? Like, do we know the benefits versus or what's better, I guess? Or is
I think I am sure they're out there. It depends on what's causing the pelvic floor dysfunction, right? Like anything.
Yeah.
If sometimes there's like irritation of the bladder and into the urethra where like the pee comes out, right?
Mm-hmm.
If sometimes medicine helps with that as well. We get patients sometimes with like a PCOS history, fibroid history, and now too, like I'm not changing that because that's structure, but sometimes medication helps with that. But in conjunction with, if these people have had these conditions for a long time, their signaling or feedback loops between brain and use of like going to the bathroom, basically, sometimes that changes and we say like, okay, it's an upregulated or very sensitive system, or we want to downregulate it, or it just basically results in other day-to-day changes that we can address. So I would say, I don't know if there's studies comparing medication to, let's say, pelvic floor, PT, and exercises against each other. I would have to look into that more, and I would say it is diagnosis dependent.
So like everything in healthcare, it depends.
Yeah.
Like, it depends on the condition, it depends on what the person's going through.
Yeah, absolutely.
Let's say in spirit of a great professor from Seton Hall, it's a gray area.
That's right. Even like constipation a lot of times will result in like other pelvic floor impairments, pain, that kind of thing. It's very interesting to me too how bladder and bowel, just our daily habits, have so much of an impact, and vice versa, on the pelvic floor area and function. And who would have thought or known that? We kind of just, I have to go to the bathroom, whatever, I'm going to go, or I haven't gone poo in 3 days or 4 days, and I can't get it out or whatever. We don't realize like sometimes the habits we have and how they're going to affect us short term, long term, that kind of thing. So that's where we come in. A lot of education.
Oh yeah, education I feel like is the biggest part of it, especially because it's such a sensitive area too. Like you've walked me through what your evals look like also, which you told me like there's certain things you do on an eval and certain things that you don't do on an eval, because it's all about getting the patient comfortable. Because I mean, if we don't want to talk about this stuff with our friends and family, we probably don't want to talk about it so much so with a stranger at first too, even if they are, you go to a doctor, we're all nervous to talk about our problems at first too.
Yeah, there's always some wonky stuff to talk about.
There definitely can be.
I almost feel like sometimes, depending on the patient, like they'll be more willing to talk to us. Like I know I have some patients that are like, well, I never talked to anybody about this so-and-so condition, but it's because like, I guess they know we're there for like healthcare, that they're, I guess, more willing to. Then some people won't even say anything to me, so I guess it can be either way.
And sometimes you get the open book patients who are like, just they'll tell you everything about themselves, their husbands, their kids. You'll know about their aunts and uncles too.
Yep, and then you're like, so what's going on with you?
Circle back. That's my favorite phrase. Circle back. Let's circle back.
Yeah. So what we were talking about before, which also for us, with anything, of course, even with physical therapy, that we have misconceptions that a lot of people talk about. Also, are there common misconceptions that you think of, Hun, that for pelvic, or that people have about pelvic floor therapy?
I don't really know. Like, it's not like I've had patients come and say, "Oh yeah, this place was." I don't, like I thought it was going to be this, but it's this. They kind of just still go with what we talk about. I will say though, like we can get into this more too, but if like any sort of internal muscle exam hasn't been talked about or discussed, I would like say that that's not true pelvic floor therapy. Now, we were talking about this the other day, but there's reasons why anyone could deny that. But if that's not talked about, educated about, or part of kind of a planned treatment to look at the muscle function in any way, it can be done externally too of your pelvic floor. So some people will say it's pelvic floor therapy because they're teaching you Kegels or core exercises, even hip exercises. Sometimes the pelvic bowl where your like ASIS, iliac crest sits, right? Even where the femur connects into that bowl has some muscular and fascial connections into the pelvic floor. So sometimes, you can use hip exercises, core exercises to address pelvic floor. But yeah, that's like my big thing. If there was no like specific pelvic floor muscle evaluation, then you didn't get, in my opinion, you didn't get pelvic floor therapy. You got a shotgun approach to maybe some pelvic floor symptoms. And my big thing about a Kegel or like a pelvic floor contraction is like a lot of people have something going on and the concept is like, oh, well, I just need to strengthen the muscle. What pelvic floor therapy helps with, number one, is are you even doing that contraction right? If the muscle is functioning properly, you should see kind of a close and a lift. And some people think they're activating and they're really pushing down or they're holding their breath with that contraction. And then the other thing I say, and everything I'm telling you guys, I explain usually in an eval too, is with that like second like level exam, you can figure out really what's going on at specific muscle groups. So sometimes with a muscle, we know this, but I think of it like an accordion, right? Like there's an optimal muscle length. So if we're too long, we don't get an optimal contraction. If we're too short, sometimes we don't get that optimal contraction, right? So right in the middle, we get our best sound, best force production. So sometimes with pelvic floor issues, we have tight or shortened muscles. So if we're already tight and short and we're constantly trying to do our Kegels and contractions, well, that's facilitating the opposite thing of what we need. But if nobody checks that on you, we don't know. So I would say, long story short, but a misconception maybe is that, oh, you're going to get just like Kegel exercises the whole time. And that's if it's appropriate for you, yes. But yeah, or like just doing core exercises is pelvic floor therapy, maybe is another like misconception. It should be very specific and like not cookie cutter at all, to like should be specific to what you're saying you're coming in for in your body, in my opinion.
Yeah, definitely. I mean, I feel like I've had numerous people tell me, they're like, oh, like, why am I going to go see that? Like, they're just going to make me do like Kegel exercises, and it's just the educating. I'm like, no, it's more than that, especially when you start to talk about the internal part of it, which is the whole point of it. I also, now talking about the anatomy portion of it, somewhere on screen, I'm going to just blow up a good old portion of what the pelvic bowl looks like somewhere so everyone can see. And correct me if I'm wrong, there are layers to it. Everyone thinks it's like it might just be a couple small muscles, but the pelvic bowl is an onion, and there's multiple layers.
Yeah, not so many layers as an onion. Yeah, and I apologize. I meant to bring home my little model, so it's a lot easier. The 3-dimensional model, it makes things a lot easier. But yes, there's 3 layers of pelvic floor muscles. Each are about like an inch or a knuckle thick. So, and their main jobs, to keep it simple, are they're like circular in nature, and they're gonna like close the openings. So when we pee, it comes from the inside to the outside. For females, that vaginal opening, we should be able to close that off, and then at the anal opening as well, right? So to be able to close. And then there's other muscles that are striated along that kind of look like hammocks, in my opinion. So you'll have your bowl, and that pelvic floor is everything kind of like tucked underneath from your pubic bone all the way wrapped around into your coccyx or tailbone too, and between those 2 sit bones. So they look like hammocks, and the other job is to kind of uplift and support those organs. So those are the 2 main jobs of the pelvic floor, all 3 layers. What's interesting is in the 3rd layer, the OI actually is considered a pelvic floor muscle, but it's also the hip muscle, so you can actually get to it and release it during a pelvic floor internal treatment. So that was one of the cool things I learned, and I love when things all kind of like connect into each other, right? So that was kind of one of my fun things. I was like, wow, that's cool. We can get to that and address that for some people too. But yes, so there's 3 official layers of the pelvic floor.
This is sort of going back to something you said before, but could you give a brief review of what a Kegel is for people who don't know a Kegel?
Yes. Okay. So a Kegel is like historically known as a contraction, or like you're gonna stop the flow of urine and tighten up those muscles down there. Sometimes you hear the word and people use it in a different way. I actually never really say the word Kegel though. When I'm working with people, I'll usually say like, try to stop the flow of urine, because people know what that means. Sometimes I've heard people say like, okay, pretend you're picking up a blueberry with your vagina muscles, right? And kind of pulling that up and in. I will say though, like that stopping the flow of urine, you don't want to just like practice that while you're actually urinating. If you have to go, just let it go. But we say that as like a cue because everyone kind of knows what that means. And we get the result, that coordinated contraction, a little bit faster a lot of times when we say that verbal cue versus the blueberry thing. But yeah, so to describe a Kegel, it's really just synonymous for tightening those pelvic floor muscles.
So what might happen if, I'm peeing and I stop myself from peeing? Why shouldn't I practice that at home?
You will explode. Sorry.
Yeah, a few times nothing's going to happen. But you want to get in the habit of when you have to go to the bathroom, just letting it come out naturally. You don't want to pull that or stop that back. Sometimes if you start doing that, it can change over time, like the signaling loop between the bladder, brain. It's a very intricate, interesting loop. But yeah, if you feel the urge, you go to the bathroom, you let it do what it needs to do, and take it from there.
Makes sense.
Speaking of the loop, you just reminded me, because you had taught me this a while ago, and it just popped back into my head, where it's like you can almost train people have trained their bladders in a sense of like when they almost, and correct me if I'm wrong, I could be wrong on this, but if they go somewhere, like all of a sudden they have the urge to have to like go to the bathroom because it's like they've kind of trained themselves in that sense. That happens too, right?
Yeah, I think like they're more like triggers versus like a training. Like the key in the door, if you're holding it or coming home from work and you put your key in the door, our brains kind of like know that we're gonna be home, gonna be relaxed, and that'll trigger an urge for people very quickly, very strong urge. Sometimes it's hard to like hold it back and like quote make it to the bathroom. Is that what you're talking about?
Yeah, similar,
or, like,
but
you
not
drive
so much
down
the
your
home.
street and
For some reason, mine's weird. Every time I go into a Marshall's, I have to go pee. I don't know why. It has nothing to do with the home, but every time I go to a Marshall's,
I don't know what it, maybe the smell, I don't know, but
yeah, I'm telling you,
who
it's weird.
knows? I don't know. Maybe the smell of
I
Marshalls.
just remembered it.
Holly,
Now I
reminds
feel like,
me.
yeah.
Holly, it reminds me of that professor I think you were talking about that like gave us that pelvic floor class. Because one of the big things she said was that it's good to have like a set routine and places, I guess, where you go throughout the day. So when you get there, your body's like, oh yeah, I'm supposed to go to the bathroom now.
Yeah, I think it depends on if you're using it for a training thing, that's one thing. But most people, we don't realize that we're either like facilitating the habit or not. Maybe that's what you were like getting at. I don't think people do it on purpose. I think a lot of times it just kind of happens.
Yeah, I see what you mean.
Interesting. Well,
So,
another question rolling forward is when should someone, and this is kind of a broad one, so there's many different reasons I'm sure, but when should someone consider seeing a pelvic floor therapist, even at a minimum?
I think with like any pelvic pain, any leakage, even if like there's a lot of heaviness, pressure in that pelvic floor area, postpartum, I think anyone postpartum really should come get an eval. That's like kind of a stretch, not, unless something's going on, but I would be happy if someone came, was like, get everything looked at strength wise, all of that.
and that's regardless of natural birth versus a C-section.
Yeah. I mean, not everyone's going to have impairments, and obviously some people, they're fine, but I think it would just be a nice idea, almost like if it's adopted, like preventative even in a way, right? Just to see, like I would say, it doesn't hurt. Get the eval. If you're strong, coordinated, everything looks good, then cool, move on. But if there's a few things you want to work on, whatever, for a month even, almost like even a screening, right? Like just to see what's going on there. That would be very interesting. I hope that becomes more popular one day. But yeah, I would say that kind of cluster of people, even anyone with like constipation, difficulty avoiding going to the bathroom.
It's a similar idea to another thing we actually talked about in school, which is just having an annual like physical therapy screen, just to see how your body's moving, how your balance is, how your strength is.
Mm-hmm.
Like it makes sense that that's something that we would do, especially after like having a baby, because it does do a lot of stuff to all that stuff.
I mean, it definitely
but it also
can. Yeah. Go ahead.
Yeah. No, it also does. I mean, it does stuff to that stuff that you're talking about, Aaron. But it also does stuff to other stuff. Like it's a big. A lot of people who, especially for like working out, don't realize that the pelvic muscles also help with stability. It's part of the whole core, like corset style stability that I was described. Yes, that helps you stay stable while exercising. So if that isn't stabilizing you, then you're also going to have problems as well.
Yeah, I think too, like I guess what Aaron, you guys are both saying, but yeah, postpartum, like even with postpartum, right? Like how's your core doing? How's the pelvic floor functioning? It'd be interesting to know. Yes, pelvic floor is also part of the core complex. So it's very interesting because you have those like pre-contracting muscles, if you will, which I also think is very interesting. If I'm going to go reach for this or go do that, everything stabilizes us so that we're stagnant here, so that we can lean and reach and we have that control. And it's one of those things that we need to have voluntarily, and also like in anticipation of an activity that's almost involuntary. We don't think about those things, right? We want to go move, and everything's kind of pre-programmed for us as well. So that's another very interesting thing with pelvic floor is sometimes, when we exercise, it's going to be voluntarily, but another function of that is to kind of pre-activate so that you can go do what you got to do. So.
Ooh. Aaron, did you say something or we losing?
No, I was just, sitting here listening.
Thinking.
Taking in the info.
Taking it in.
I heard the mic for a second, so I wasn't sure before I started. But yeah, no, it's a very important muscle group that adds a lot of stability to our everyday functioning. So it's one that it's important to all of it. Now we just kind of talked about when someone should consider seeing a pelvic floor therapist, and you had mentioned like even without any specific condition that you had mentioned before, like the PCOS or postpartum, that even it's good for anybody to see them. But are there any, and I don't want to use the word like surprising, but any like challenging conditions that you have seen before in your treatment?
Challenging conditions. Yeah, I guess it depends. I will say sometimes I would say like if it's more complex, like if there's other, maybe a past medical history or congenital diagnoses in someone's history that, you're working with, that you start to think like, okay, well, maybe there's a certain threshold that we'll get to. Like if someone is, meaning you're born with it, right? Like if you're congenitally hypermobile, well, and you have tissue laxity, and we're trying to address maybe some stability issues or screening you for a prolapse, whatever that is, not that just because you have that doesn't mean you're going to end up in pelvic floor PT either. But I would just say in general, if there's a few pre-existing conditions, or if someone is sometimes taking a lot of medications, there's side effects to that. So say it's not necessarily more difficult. It's just sometimes we have to acknowledge that and maybe change our expectation of, okay, you're going to get 100% resolution, or these things are also playing a role. So maybe we make it better, but we have to keep this, this whole global picture in mind. It's not just the one thing. So I'll say there's not one specific instance. It's just generally you're thinking about a lot more, and maybe it changes the prognosis when there's more things going on for someone than just someone who's coming in maybe for incontinence alone. Does that make sense?
Mm-hmm.
Yeah, no, That definitely does.
To sort of, I guess, flip it around on you here, are there ever any instances where people think they need pelvic floor PT and then probably don't?
That's a really good question. I have not found that yet. I feel like it's really the opposite where even I get like referrals from coworkers who are doing, let's say, low back evals, and we, in our past medical history, they'll check off a few like, GI, GU system impairments, and then they'll come to us or they'll talk to us about it. I don't really think I ever had someone at this point come in for me to say like, oh, you don't really need it. I feel like with most people, there's things, you could work on. I'll say maybe there was one time where I had someone who was like pretty well off that we treated for maybe a month or 6 weeks at once a week, and they were happy with that. I was happy with that. And then we taught them what we could, and they kind of maintained it from there. And then I would say like, okay, if anything happens or changes, you reach back out to me and we can tweak things from there. So
I guess because like pelvic floor therapy is so like specialized, most people are going to come see you because that's what they're looking for.
Yeah.
Like it's usually probably not some weird outlier, or you probably wouldn't see like refer someplace else.
Yeah, usually no. Usually they've been dealing with what they're dealing with for a long time, and they've gone, like I was saying, they've gone to a few different doctors' places. They're looking for results. And we're like the last ditch effort, and at that point, like we really can make a difference. So they're the ones who like really need it, and that's a lot of times who gets it. I think maybe that'll change going forward, but right now, yeah, no.
Well, I guess
that's always the hope. And sorry, go ahead.
Well, I was gonna say that's what makes it more rewarding too. It's like the last thing that people can rely on to get them where they need to go. And then when you actually get to see them improve, it's always very nice.
Yeah. I will say too, I don't want to mislead you guys. It's definitely a medical team effort a lot of the time too. Like, we're usually like that last little push. It's not just us a lot, but it's a big factor to get some relief for some people.
Mm-hmm. Yeah,
I see where you're coming from. I'm sure we're gonna hope that over time that like you're saying, like these people have been dealing with the condition for a long period of time, and of course our goal is to shorten that length of time where maybe these people can start to find you guys faster than having to wait and jump from doctor to doctor. It starts to spread a little bit more that this is something that offers relief for many people, and is proven in research to work, and you're changing many lives doing it.
Oh yeah.
I mean, all of this.
And then what you kind of sorry, go ahead.
Yeah, I was gonna say all of this just makes me think of, I guess, direct access and how we should try to use it a lot more, because there are definitely things, even though, like Holli said, it's supposed to be like a whole team, everyone's working together. There's probably instances too for all three of us where we don't need necessarily a referral in order to work with people for some of these issues.
Yeah. I mean, I'm not shy. If somebody came to me and I thought that they needed to be seen by someone else before we moved on with our kind of, I'll you're there for them, and that's the right thing to do too. So either way, that's part of our job as being direct access providers is, okay, yeah, we're here, we can do something, but you also need to go X, Y, Z because of whatever reason, right?
Yeah.
Direct.
Yeah.
Exactly.
Direct access is
and
definitely...
guide.
It's definitely something not used a lot for geriatrics.
No, yeah, probably not, right? A lot of them have to follow insurance rules as well, right? So
yeah, because everybody has Medicare, so most of the time we have to get a script right away.
Right.
Yeah, good old insurance. I can get on a soapbox, but we don't have to.
And you're doing home calls too, or no, not anymore, right, Aaron?
No, I still am. I'm doing a few. I would say maybe 25% of my day is at people's house. 75% is at a facility. So,
okay. Yeah, I feel like. Go ahead.
No, you're good.
I was just gonna say in that setting, if you're doing home calls, they're not gonna like call you and be like, "Hey, can you come?" It's like set up for you, basically. Usually, right? Like they find out that they need the therapy because there's a referral or prescription. Is that usually how it goes?
So actually, a lot of times people will call me directly and be like, "Can I start therapy?" And then be like, "We need a script," and then we go from there. So there's a few different instances. If it's like a patient I've had before in the community, they'll just call me and they know that I will set things in motion and get the script that they need. In the facility itself, our cards are like just throughout the building. So if someone wants therapy, they can either call me or just come right to the gym that we have. So that actually happened like this week. Someone called me and asked to start therapy.
Oh, wow. Oh, so see?
Mm-hmm. Which
Learn something new.
I guess I still wouldn't call that direct access. I guess it sort of is, but like you still need the script from the physician to do it. Yeah.
Yeah. Yeah.
And the physician is in-house. That's what kind of makes it indirect direct access, right?
Well, he's there once a week, and we won't go too far into that.
Yeah, of course.
Down the rabbit hole. I'm a curious person, so.
No, it was a good question.
Circling back to something you had mentioned before, Hal, was you'll have like coworkers of yours who will do an eval and kind of see something and talk to you about it or refer to you. Kind of leads us into the idea of like, can pelvic floor, like poor coordination with your pelvic floor, be the cause of some of the problems, or at least part of the problem that these people are being the other therapists for? Like, let's say like low back pain or something like that too.
Yeah, it definitely can correlate and relate if you're looking at, how chronic something is, right? And what's changed and been going on with their coordination, ability to activate core, all that. So yeah, sometimes it is. To really be 100% sure, you have to do your eval and see from a pelvic floor PT, it's an interesting perspective. If we do get low back, I've had one pelvic that I thought a lot of her stuff was coming from some of her back. That was, so it's like starting there and then trickling down into some other pelvic floor things. So we got to treat both at the same time. So yeah, I definitely think it can happen. It's not as common, but can happen.
Seen it before. It's interesting though to think about that. It's like it goes into that stability factor that we were talking about earlier. That if that's not there, then it can kind of cascade into other problems too.
Yeah.
Yeah.
One thing that.
Go ahead. Go for it. I was just gonna say like, the whole body's connected. So one thing can affect another thing, can affect another thing, and sometimes the thing that you go in for, you didn't expect to be related to another thing, and then it is.
Yeah, and then you're like, wow. The one thing that I found very interesting was the effect on breathing. Took a class like all in breathing, and before, like, I mean, we kind of all know, breathing's good, but it seems so simple, and you're like, really, is it that important? I use it so much now too, and you think about like changes in pressure, like trunk stability, recruiting your diaphragm and the effect that has on our nervous system. The relationship that actually has too on our pelvic floor, and the change in pressure in these cavities. It wasn't even a pelvic floor course, which is really funny, but it gave me a lot of appreciation for breathing and diaphragmatic breathing in particular. And I, before then, didn't like, we all knew, okay, yeah, it's good, but using breathing to also affect or change movement or tap into other areas was very interesting too. So don't sleep on the breathing.
Yeah, that makes a lot of sense for me too, with like patients with COPD or heart issues, any problems with breathing. I never really thought about like pelvic floor as part of, I guess, activation of everything for their breathing, but it makes sense. I actually have one lady with. Maybe I shouldn't talk about my patients. Never mind. I'll just change the subject.
Well, now we know you. At least you've got one lady.
Yeah.
There we go.
But yeah, no, it is interesting to think about. It's like they're not too far away from each other.
No.
The pelvic floor muscles, and they're working inside of the same pressure system that is like the intra-abdominal area. So it's. Yeah, if one side is weak or not coordinated with the other, then you're going to start to lose some of that balance inside of there too. So I do find it interesting that like the breath work also helps with that like control as well too.
Yeah,
absolutely.
It does make sense. It's like we know that activating like your lower back muscles probably will activate your like transverse abdominis, and then that probably activates your pelvic floor. So like why wouldn't it like activate the diaphragm as well if they're all sort of in that little area putting everything together.
Yeah.
Sort of makes sense.
Oh yeah. And then too, like the whole I get so excited about it. I'm like, oh, who knew about all this? I'll too educate sometimes with breathing and like bowel movement. So instead of like pushing to strain, using breath and like that box breathing. I don't know if you've heard of that before too, where you breathe in, you kind of hold, and you breathe out and you hold for a certain amount of seconds. But using the breath to help to create change those pressures as well. It helps with bowel movements. It's like, wow, who knew?
So, if you're really straining to drop the deuce, do you want to breathe out and drop the deuce, or do you want to hold and drop the deuce?
The box breathing is my favorite. So you incorporate a little bit of each. So you would breathe in for like 5 to 7 seconds, kind of hold that for 5 to 7 seconds, breathe out, and then try to hold, like pause that and hold that again.
But then, like, when do you try to go? Or does
Aaron,
that
it
usually help you go just by doing that?
Training in and of itself, like if you're trying to force it out, that's like an active maneuver.
Gotcha.
Right, it's active. Usually though, like voiding, we'll say, right, is passive, meaning if you should be able to relax, because if you're activating, let's say, those sphincter or circular muscles, they're going to pull in this way if you're trying to use them, let's say, right? So it'll facilitate that. But if the more relaxed you are, actually, the more you tap into that rest and digest nervous system. Think of it this way: rest and digest. Well, going to the bathroom in that regard is part of our digestive system. So if we're trying to strain and we're getting stressed about this, that's going to stimulate more of that fight or flight. And that's not going to help us kind of pass the stool through. It just is more aggravating and takes more time, honestly.
So that makes sense. So you don't try to force it. You just sort of let everything flow.
Yeah, and then too, with like chronic forcing and straining, changes those like pressure differentials and can in time like create more laxity in the pelvic floor tissues and create a lot of this like pressure and stretching down. Talking chronic, but over time, if you have a habit of that, that can lead to some other things that you don't want. So trying to get everything moving along as simple, as easy as possible is the best way.
Yeah, I've had a bunch of patients, not a bunch, I've had a few patients that have had like constipation for a long time, and pain is actually a big thing for them, like either abdominal or low back pain, just from like straining to try to get things out. Yeah.
It can be complicated too. Sometimes people do that. Like it could be a few things, right? But like that double voiding or incomplete emptying, we'll say too. Depends on, again, medications, a few things. I always say though too, like if you've been kind of sitting and waiting for more than 5 minutes, just get up and move around, walk. You can even kind of, if you're sitting there and it's like frustrating to come out, kind of rock the pelvis around, shake things up a little bit, but not vigorous, but rock the pelvis. If that doesn't work, then just get up and try to move on. It's a little frustrating because you get that urge and you just want that urge to pass. But also, like, sitting on the toilet for 10, 15, 20 minutes is not the best for us either, if you can avoid that. So move along and circle back for that as well.
That makes me think
I was going to say, I feel like... Go ahead, Aaron.
I was going to say, that makes me think of two things. First of all, it reminds me of just being in the hospital. Not as a patient, but as like a physical therapist. There's a lot of times where like nurses and doctors actually want therapists to come and get someone out of bed so they can go to the bathroom. The other thing was not as serious. If you sit on the toilet for too long, I call it dumper's leg, when you can't feel your legs and you have trouble walking. So don't do that.
That's a new term. I haven't heard that one before. Would you say dumper's leg?
Dumper's leg, because you're taking a dump and your leg falls asleep. I made that up. That's not a real thing.
God.
Dumper's leg.
Don't Google it; it won't pop up. But no, I was gonna say, now it's so much more common seeing it, especially in the day of smartphones, when everybody you just sit I'm sure you've had many patients tell you that they end up sitting on the toilet for so long because we're just we start to scroll away and
no scrolling.
10, 15 minutes pass.
No scrolling during any bowel or bladder avoiding. No,
I definitely didn't do that this weekend.
No. No. It's so good. Like you said, it distracts you, and then you don't realize how long you were sitting there. Then you get dumper slide. No one's happy.
And then you can't get relaxed either, and then nothing's moving, and not a good time for anybody.
No one's happy.
I believe it or not, we are rounding up, coming closer to an hour. I'm getting some weird noises.
Uh-oh.
Did we lose Tommy?
Wasn't me.
Holly, you're good. I think I'm good.
I think it's Tommy. There we go.
There he is. Back in it. But what I was going to say is, Holly, believe it or not, we're already coming up close to an hour.
Wow. That was fast.
Do you have any closing comments, anything that you would like to bring up, anything that we feel like we might have missed in this whole conversation?
Not really, and I hope not, but...
No, I do think it was very thorough. We talked about a lot of stuff. You gave us a lot of good information, a lot of stuff I haven't really thought about a lot in a long time, honestly. So definitely thank you for coming on.
No problem. This was a lot of fun. You're welcome.
I'm back now. I all of a sudden lost. I'm sorry. I just decided to disconnect my headphones. I don't know what happened there, but yeah, we went over a lot of really good stuff. It was awesome.
Yeah, I think too. Sometimes it's a lot to cover. Even in an hour and going back and forth. And I try to keep it as broad based and as simple as possible. So there's obviously more. We could always talk more about things.
We didn't even go into an internal pelvic exam, and that's something that I think a lot of people don't know a lot about. And my knowledge is that 2-hour class that Holly and I did when we were in school, so it's a little bit limited as well. But hey, maybe that's a part 2.
Yeah.
Yeah, I mean, go ahead, Tommy.
No, I was gonna say that could be a part 2, and then we can also bring in how it's related to like the fitness side of it too, how it affects athletes and everything as well. On their scale.
Mm-hmm. Oh yeah.
All right. Well, I guess we'll wrap it up there. Thank you again, Holly, for coming on.
Thank you for having me.
Do you have any plugs?
Plugs.
Or do you think you're good there? Anything you want to plug? Anyone you want to shout out?
Oh, I don't know.
That's okay.
You put me on the spot.
I'm putting you on the spot right now.
Thanks to anybody who taught me anything and guided me along my journey. Appreciate that so much.
All right. With that,
if you're having troubles, see your pelvic floor therapist.
There you go.
Sounds good to me. All right, everybody. Have a nice night.
Talk to you soon.